Management of latent TB infection in children and adolescents. Content, background, rationale for treatment of latent TB infection, identification of eligible individuals for TPT, contact investigation and management, treatment of latent TB infection regimen options, monitoring of patients taking TPT. Overview of TB transmission, latent TB. This diagram shows TB transmission. Difference between latent TB, latent and active TB. Characteristics. Mycobacterium tuberculosis in the body. Latent TB infection. Yes, small in number, alive, but inactive. Active TB, yes, large in number. Characteristic tuberculin skin test reaction. Latent TB infection positive. Active TBD is positive. Characteristics symptoms. Latent TB infection no. Active TB disease yes. Chest X-ray. Latent TB infection normal. Active TB disease abnormal if pulmonary. Sputum smear and cultures. Latent TB infection negative, but active TB is positive. Infectiousness. Latent TB infection not. Active TB is pulmonary TB is infectious. In case of TB, latent TB infection no. Active TB is yes. Treatment. Latent TB infection treat with TPT. Active TB is full course TB treatment. Background. 1/4 of the world population estimated to be infected with TB. On average, about 5 to 10% of those infected will develop TB disease over the course of their lives, most of them within the first 5 years after initial infection. The risk of TB disease after infection depends on several factors, the most important being weakened immunological status. Risk of developing active TB following exposures to TB. 75% of people who develop active TB disease after coming into contact with someone with TB do so within 1 year of TB diagnosis of the index patient, and 97% develop TB within 2 years. TB preventive interventions are key components of NDTB strategy to reduce the risk of occurrence of new TB cases and to achieve the NDTB strategy targets set for 2030 and 2035. While TPT services are gradually expanding globally, access among persons at risk remains low. According to the 2020 Global TB Report, 21% of the 3 million targets were initiated on TPT in 2018 up to 2019. 88% people living with HIV, 20% household contacts greater than 5 years, and greater than 1% household contacts aged 5 years and above. Multiple losses in the TPT cascade of care. Systematic review and meta-analysis in 2015 data from developed countries steps in CDC associated with greater losses. Testing and screening remain big barriers. Acceptance is high. Poor treatment completion, less than 20%. factors associated with lower fewer losses were immune, compromising medical indications, being part of contact investigations, and the use of rifampicin-based regimen. Programmatic management of TB preventive therapy. Latent tuberculosis infection is defined as a state of persistent immune response to stimulation by Mycobacterium tuberculosis antigens with no evidence of clinically manifest active TB. Programmatic management of TB preventive treatment (PMTPT) includes all coordinated activities by public and private health caregivers and the community aimed at scaling up TB preventive treatment for people who need it. TB preventive treatment (TPT) treatment offered to individuals who are considered to be at risk of developing TB disease in order to reduce that risk, also referred to as treatment of TB infection or latent TB treatment. Benefits of TB preventive therapy: reduce the risk of TB incidence and mortality among high-risk groups by alleviating the risk of progression of latent TB infection into active TB disease. Strategically, by intervention to achieve end TB target by 2030 or 50, critical and ambitious target set for TPD at UNHLM in 2018. Cost-effective intervention reduces the burden of tuberculosis into the health system and individuals or community. Management of latent TB requires a comprehensive package of interventions that includes identification and testing of individuals at increased risk of acquiring latent TB, administering effective treatment with regimen preferred to promote adherence and with no or minimal risk of adverse events, and ensuring monitoring and evaluation of the process. Identification of population for TB preventive treatment. The priority risk groups for TPT includes people living with HIV, pleural, infants less than 12 months living with HIV having contact history with pulmonary TB, children greater than or equals to 12 months having with HIV, adolescents and adults living with HIV, children and adolescents aged less than 15 years, 0 to 4 years, 5 to 14 years who are exposed to pulmonary TB index gas. Reaching eligible individuals for TPT. People living with HIV, all pleural should be screened for TB symptoms at every opportunity or when in contact with a health worker. Those with TB symptoms should be referred for diagnostic testing, and those without symptoms should be evaluated for eligibility and started on TPT as appropriate. HIV negative household contacts. Systematic contact screening and management either at health facility level or community level. Testing for TB infection. No gold standard test for TB infection. Currently available tests for TB infection include tuberculin skin test, TST, blood test, interferon gamma releasing assay, IgRA. Either TST or IgRA can be used for specific populations at risk of TB infection whenever feasible and available. The use of test of TB infection is not a requirement to provide TPT for eligible people living with HIV and less than 15 years household contacts. Absence of test of infection should not be a barrier for TPT. Systematic screening and management of contacts. In these cases, the initially identified person of any age who is new or recurrent TB in a specific household or other comparable setting in which others may have been exposed. And in these cases, the person on whom a contact investigation is centered, but is not necessarily the source case. Contact any person who has been exposed to a person with TB or index case. Household contact a person who shared the same enclosed living space as the index case for one or more nights or for frequent or extended daytime periods during the 3 months before the start of the current TB treatment episode. Contact investigation. Close contact. A person who is not in the household but who shared an enclosed space such as a social gathering place, workplace, or facility with the index case for extended daytime periods during the 3 months before the start of the current TB treatment episode. Contact investigation is a systematic process of identifying previously undiagnosed people with TB disease and the TB infection among the contacts of an index TB patient and or other comparable settings where transmission occurs. Goals of contact investigation. The main purposes of contact screening and management include early case finding of tuberculosis among contacts, helps to identify contacts of all ages with undiagnosed TB disease among the contacts of the index case and the prevention of incident TB disease among contacts, provision of TB preventive therapy for contacts at highest risk of developing active TB disease, breaking the chain of transmission of TB. Cascade of the TB case finding and the TPT. This is the cascade. The first one is target population, and the second is active TB case finding. That's presumptive TB, no TB, test for TB disease, rule out TB disease, clinical hydrograph, testing for TB infection, TB confirmed, no TB, provide TB treatment, assess for TPT, systematic recording and evaluation. Conducting systematic contact investigation. Priority for conducting contact investigation should be given when the index TB case either has infectious pulmonary TB, has presumptive or confirmed drug-resistant TB, is a child under 15 years of age, or is a pupil living with HIV from high-risk congregated settings such as prison, homeless shelters. Steps in systematic contact investigation. First, the TB focal should interview the index case person upon registering as a part of preparation for TB treatment. 2. While interviewing, assess the risk of exposure, determine the need for contact investigation, and identify a list of potential contacts that require additional medical evaluation and management. 3. Counsel index patient and enumerate household and those contacts. 4. Develop plan for contact investigation in consultation with index patient or guardians. Interview with index case as soon as possible to assess the need for contact tracing. Educate the patient on the need and the benefits of contact investigation. Equals to or greater than informed decision. Identify and list the details of the contacts to the to be approached. 5. Consider other contacts for investigation such as in the workplace, school. 6. Conduct home visits or visit contacts to health centers for the identification and the initial assessment of contacts at home or health facility. If household close contacts are identified, communicate with the responsible health extension worker. The health extension worker should identify the host of the index case and conduct the initial screening using symptom-based TB screening questions at home. Identify and refer contacts with presumptive TB for evaluation and eligible household contacts requiring TPT to catchment health facility. 7. Conduct appropriate clinical evaluation and management of TB exposed contacts. All foreign contact should receive appropriate clinical and laboratory evaluation and subsequent management, depending on various patient-related factors and medical conditions. The TB focal person should arrange for evaluation of referred case. 8. Provide treatment for TBDs or TPT as per eligibility. 9. Completeness of contact investigation. 10. Ensure systematic recording and reporting.